Hi, I'm Gilles Freyer. I'm a medical oncologist in Lyon, France. I'm very happy to present you this clinical case, mainly focused on abemaciclib tolerance. These are my disclosures. We are talking about a 51-year-old postmenopausal patient with a history of breast cancer. It was a luminal tumor at the age of 44, and she received adjuvant chemotherapy and, of course, radiotherapy and hormone therapy with tamoxifen. And after 2 years of follow-up, we unfortunately observed a liver relapse, which was confirmed by a biopsy showing the same histology. You can see the multiple liver metastases on the CT scan, and according to the current recommendations, she's now receiving a combination of letrozole and abemaciclib with a continuous dosing, 150 milligrams BID. And her concomitant medications are mirtazapine and sotalol for a benign arrhythmia. And it's really important to take care about potential drug-drug interactions. And there are no interactions between abemaciclib and mirtazapine. There is no direct interaction also with sotalol. However, as you know, sotalol may increase the QT interval. And I think it's important to follow those patients, even if we observed no QT increase in the trials using abemaciclib, but it could be a class effect that was observed, for instance, with ribociclib. And I think it's important to follow the patients receiving a beta blocker such as sotalol. And here we have a table showing the metabolic pathways of abemaciclib, and particularly CYP3A inhibition and induction. We need to avoid potent CYP inducers such as rifampicin, CYP inhibitors such as clarithromycin, and you need to remember that a simple glass of grapefruit juice may increase the concentration and so the toxicity of abemaciclib. After 7 days of treatment, the patient experiences a grade 2 diarrhea, and in this case, would you recommend at first occurrence of diarrhea? Stop the treatment, reduce dosage, take loperamide, take racecadotril, and take probiotics? It's a question that we ask to the audience, and you have a few seconds to express your own choice. We need to remind that in the clinical trials involving abemaciclib, diarrhea is a very frequent adverse event. It's observed in more than 80-85% of patients, with around 30% of grade 2 and 10 to 13% of grade 3, which is I would say clinically meaningful. So it's a very important adverse event to manage. And we have some recommendations regarding the grade of toxicity. You have to remember that the grade of toxicity is based on the increase of the number of stools per day, and also the clinical consequences such as dehydration of requiring hospitalization. And here we have a grade 2, and with a grade 2, it's not appropriate to modify the treatment. It should just be stopped until the patient recovers. And of course, we have to introduce a symptomatic treatment, which is loperamide in a majority of cases. And in this patient, the diarrhea will resolve to grade 1 after 1 day, and she now can continue the treatment as prescribed initially with the same dose. And as it was observed in the Monarch 3 trials and in other trials, including abemaciclib use, the incidence of diarrhea will decrease with time, and it's mainly due to an appropriate management of this side effect by using loperamide and also by adjusting the abemaciclib dosage when it's appropriate. After 2 weeks of treatment, the creatinine level increased from 68 to 95, and the GFR, of course, decreased from 89 to 57. And the patient is now asymptomatic. She has no diarrhea, no dehydration, no sign of denutrition. And this phenomenon is due to a reduction of the tubular secretion of creatinine, which is directly induced by abemaciclib, mainly by inhibiting some genes such as the MAT genes, but it may also be induced by other drugs. I have personally observed such a phenomenon with some PARP inhibitors, for example, but it was clearly described with abemaciclib. And in this patient, so we have no renal insufficiency. It's not a renal toxicity. It's a simple chemical phenomenon. I would say it's an artificial increase of serum creatinine. And so we cannot measure the glomerular filtration rate by using formula such as Cockcroft or Jelif or MDRD. They are inappropriate. And we can perform exact measures of such as iohexol clearance or EDTA clearance, but a more simple formula may be used by cystatin C assay and then use of this specific formula that you can find by using this web link. And by using cystatin C, we have GFR of 84 instead of 68 after abemaciclib intake. And of course, abema was continued at full dose, and it's very important because we can expect a clinically meaningful improvement in terms of PFS, 28 months, for instance, in the Monarch 3 trial, with potential effect on overall survival, as it was suggested in some recent meta-analysis, and we hope confirmed in the near future. And of course, to achieve this goal, a careful patient's follow-up is necessary, particularly regarding diarrhea during the first 2 months. So thank you for your attention.